our speaker today is Dr. Olivio from the Department of Psychology. And since he specializes in gerontology, aging, and issues like that, I can be forgiven for pulling out my notes if I need to. As a matter of fact, I was, as an undergraduate, I was a philosophy and psychology major, not an English major. And just a few months ago, I wrote to my psychology professor, who's now in his early 80s, thanking him for his kindness and his help when I was an undergraduate. And among the things he said a lot of nice things, but he said, it's very typical of people of your age to want to get in contact with, so I felt this was by the kind of a slight decline, reaching out to other people, and the next news of further decline will be a lot more frightening. And when I look over what Dr. Clay has written about fluid intelligence and memory span, I get a little bit frightened. But on the other hand, specifically because of that fright, and today relating it to diabetes and disparities in the treatment of African Americans and white populations with these diseases, it's all the more relevant whether one likes it or not. So without further ado,
All right, I'd like to thank everyone for coming out today. I know this is a weird time of the between semester period, so I appreciate everyone's attendance and everyone who will watch the video clip later on. First, I'd like to add a little theory to my introduction before I get started with my talk. In gerontology, there's a theory called Socio-Emotional Selectivity. And again, that relates to my introduction. It says, as we age and become more aware of our own mortality, we tend to seek out relationships that we consider more meaningful to us. So the size of our social support networks as we age decrease overall in general, because as we age, our friends pass away, die, move away. We're not in contact with as many people over time, but we tend to treat those relationships that we consider as close as being more beneficial, and we really seek out those relationships a little more. So maybe that's an example of socio-emotional selectivity. You being in contact with your former mentor, seeking out that meaningful relationship. And as we go into health disparities, we know that that's a broad topic. We know that we're not going to be able to give a full overview in the short amount of time that I have with you today, but I specifically want to talk about older adults with diabetes, racial differences between African Americans and Caucasians, and specifically on outcomes of mobility. So trying to determine what is associated with mobility limitations in older adults, African Americans and Caucasians. So I'm going to give an overview of what diabetes is, specifically type 2, because as we age, that's by far the most common type of diabetes. So what is type 2 diabetes? Why is it important to study it? And why I, as a psychologist, decided to study older adults with type 2 diabetes. All right, so as we know, type 2 is when your body either does not produce enough insulin or your cells ignore the insulin that is actually produced by your body. And it's necessary to convert the glucose into energy. And when you eat food, the body breaks down all the sugars and starches in the glucose, and that's our basic fuel, and that insulin takes the sugar and blood into the cells. Where the problem actually occurs is when glucose actually builds up in your bloodstream and it's not actually going into your cells. That's where you can get complications associated with diabetes. So a brief look at the prevalence of type 2 diabetes. So if you look at all adults age 20 and over, you see that non-Hispanic African Americans and Hispanics have higher rates compared to non-Hispanic whites and Asian Americans. When you consider the different age groups, older adults have the highest rate of diabetes. And here's a fact that we should not be so proud of. Here in Alabama, when you look at the 2010 Behavioral Risk Factor Surveillance System, so that is a by-state survey of all non-institutionalized adults, we see that Alabama ranked #1 as far as the prevalence of diabetes at 13.2%. So again, a fact that we should not be proud of. Hopefully, as a result of some of the things that we're doing, we can help bring those numbers down. Why is it important to study it? Individuals who have been diagnosed with diabetes have healthcare costs that are estimated to be somewhere around 2.3 times higher than individuals without diabetes. That's one important reason. And also looking at the complications associated with having diabetes. So if you do have that diabetes diagnosis, you're at increased risk of cardiovascular disease, neuropathy, stroke, vision loss, cognitive impairment, among other things. And all of these things that I just mentioned can contribute to mobility limitations in older adults. All right, so why did I become interested in studying type 2 diabetes, or diabetes specifically? So here's a picture in 2006 from my wedding. You have 3 generations of the Clay family here. You have my grandmom and grandfather, that's Frank Clay, that's Matilda Clay. So, you know, we've all heard stories of, well, you guys have it easy. We had to walk 30 miles to get to school, and we worked in the snow. That's right, in the snow. But I really think compared to the lives that they lived, I really have it easy, because we're from a rural, poor area in Alabama, in the northwest corner of Alabama. And while they were growing up and into their early adulthood years, they actually had jobs where they actually had to go out and pick cotton. I mean, physically, by hand, pick cotton, put it in a bag, put it over your shoulder, and carry it around with you. So they actually had those kind of jobs in their early adulthood life. So that's my grandmom and grandfather. That's my mother, Mary Clay Williams, and myself and my wife. So as you notice, here's my grandmom. As you notice, she's in a wheelchair in this picture. She had at that time type 2 diabetes, and she had the complications associated with the disease. So she had neuropathy, which we'll talk about in a minute. So with neuropathy, which we'll talk about in a couple of slides, you have loss of feeling in your extremities. So because of that, she had an injury that led to an amputation. So therefore, diabetes led to the amputation, led to mobility decline, which led to other things. So that's really, and so since she had type 2 diabetes, we have the family history. So my mom has it. So again, there's that family history. So I better be on the lookout. So that's what made me interested in studying diabetes. All right, so let's talk specifically about neuropathy. Again, we don't have time to talk about all of the complications associated with diabetes, but neuropathy is a very important one. That's nerve damage to your peripheral nervous system due to that high glucose buildup in your bloodstream. Approximately half to 70% of individuals with diabetes will develop neuropathy to some point. And if there's pain associated with the neuropathy, it's frequently described as a tingling or burning feeling. But as you know, since there is that depth of tissue, there's a numbness associated with this as well, so you lose your feeling. And with that, you can have injuries such as, you know, having your hand on a hot stove and getting burned, or spilling something on your feet, which happened to my grandma. She was making some hot tea, so she spilled it on her foot. Because of the neuropathy, she couldn't feel it. So, again, associated with that, when you have diabetes, your injuries don't heal as well. So that led to amputating a couple of toes, to part of the foot, to the foot, and going on up with the amputation. So the neuropathy was one of her major complications associated with diabetes that led to other things. All right, we have any animal lovers? All right, we got a couple of animal lovers in the audience. So here's man and man's best friend. So anybody have a dog? All right. So we know our animals, and if we have them over a period of time, we develop that bond with our animals. We know we take care of them, and they take care of us as well. So here's a Michigan man. His animal, in the animal's opinion, was taking good care of his provider. And we know the guy here, we see he has his leg propped up. Anybody have any idea why he has his leg propped up? Actually, this gentleman did not know that he had type 2 diabetes. He had developed neuropathy, so he didn't have any feeling in his extremities, specifically in his feet. Therefore, he was experiencing the death of tissue in his feet. So that death of the tissue actually gave off a smell, which the dog was able to smell. So what do you think the dog did? Chewed his foot. Oh. Sure did. Sure did. Actually, in this case, some people might say that the dog actually saved this guy's life, because he didn't know he had type 2 diabetes. I don't know how he didn't know he had neuropathy, but he didn't know that he had lost feeling in his foot. And so in the dog's opinion, he was doing his master a favor by getting rid of that tissue that was dead already. And you know, I thought this was kind of like a freak occurrence, but I gave a talk similar to this over at the UAB Health Smart Clinic, and there were individuals from the audience who were coming to me and say, yeah, we know of a similar case that happened right here. And I also attended a conference in DC where a podiatrist came up to me, and he was talking about a similar case. So this is very, very common that individuals have so much cell death due to neuropathy that instances like this happen. All right, so why is it important to identify individuals with mobility limitations, or individuals who are at risk of having mobility limitations? So those mobility problems are associated with negative outcomes. They have a higher risk of falling, higher risk of being hospitalized, more activities of daily living problems like toileting and bathing, a higher risk of nursing home placement, and a higher risk of mortality. So again, mobility limitations in older adults are associated with these negative outcomes. Some previous literature, as far as disability, it's been categorized in some instances as having difficulties with some of these instrumental activities of daily living, such as walking a quarter of a mile, climbing 10 stairs, or doing housework. So analysis from a national data set of community dwelling older adults found that approximately 32% of women and 15% of men with diabetes were categorized as having a disability, compared to only 14% of women and 8% of men without diabetes. So as you can see, having diabetes in older adults is associated with disability from this example. So now I'd like to talk briefly about our study. I'm the co-PI with Dr. Crow from the psychology department on this project. We call it DASH, the Diabetes and Aging Study of Health. So it's an observational study of adults 65 and older, mainly African American and Caucasian, who self-report a diabetes diagnosis. And some of our aims excuse me, are to look at measures that are associated with mobility within this sample, to determine if there are racial differences in mobility, and once we identify things that are associated with mobility, can we modify some of these things and develop interventions that will alleviate some of these mobility problems? All right. Excuse me. So we were able to recruit approximately 250 people. We utilized the Center for Translational Research on Aging and Mobility recruitment database. Dr. Carleen Ball is the head of that center. We added response cards to an ongoing study excuse me, to recruit some of their individuals who were ineligible because they had diabetes. And Dr. Fernando Ovalle is one of our co-investigators. He's the director of the UAB Diabetes and Endocrine Clinic over at Kirkland Clinic, and we recruited individuals from the clinic. So we have a sample that's approximately 2/3 from the community, 1/3 from the clinic. Of course, we went through the dreaded IRB, got our IRB approval. These were mainly telephone interviews, so we did verbal informed consent. We were able to do an in-person assessment at 1 year on some of our individuals, and a follow-up 2-year telephone interview as well. Excuse me. Here's our main assessment of mobility, the life space assessment. And what it does, it looks at an individual's movement within the last 4 weeks, and it ranges asking them questions about were they able to leave the room in which they sleep, to were they able to go outside their own town, and it asks about the frequency that they were able to do these things on a weekly basis, and if they needed the assistance of a device such as a walker, or if they needed someone else's assistance to actually be able to go to these places. And it has a composite score of 0 to 120. All right, so let's get a visual display to kind of see what life space looks like. So again, it ranges from being able to move beyond the bedroom where you sleep to outside of town. Individuals in this restricted range that would correspond to a score of 60 or below are considered to have restricted life space. And individuals with restricted life space or restricted mobility are at higher risk of having negative outcomes. So this is our main measure that we're looking at for this talk, life space mobility. We looked at demographic measures, age, gender, education as a measure of socioeconomic status and race. Multiple measures of physical health, number of physician visits they had, how they self-rated their health on a scale of excellent, very good, good, fair, or poor, and any comorbid conditions they had, such as neuropathy, stroke, arthritis, etc. We had two main measures of mental health that we looked at for these analyses. So we looked at their cognitive functioning, and again, these numbers that I'm going to present today are based upon our baseline data, so it was a telephone interview. So we used a standardized cognitive functioning measure that can be administered over the phone that assesses multiple domains, and we had a measure of depressive symptoms. Then we had measures that were specifically related to that person having diabetes. So we had a measure of diabetes knowledge that was 10 items, and it was developed in such a way that even if individuals had lower levels of education, that they should be able to answer those questions. And we had a two-item measure of diabetes distress. So how was dealing with diabetes really stressful for those individuals or not? All right, here's your test. We got a test. What's a normal hemoglobin A1c or average blood sugar test for an individual? So when we go through this 10-item skill D, this is one of the questions that the individuals who come in for our study are asked to answer. What's the normal hemoglobin A1c? If they don't know what hemoglobin A1c, that's why we add average. That's why average blood sugar test is added. Again, it was designed for individuals who might not have a high level of education. All right, so first question on the test. Average normal hemoglobin A1c. Anybody know? Go ahead.
7 or below?
For an individual with diabetes, 7 or below is exactly right. For an individual who hasn't been diagnosed with diabetes, they would want to keep around 6 or below. Exactly right. Number 2, signs and symptoms of high blood sugar. Again, everyone that if their blood sugar levels are high will not have the exact same symptoms, but there are a list of common symptoms that will occur if an individual's blood sugar level is actually high.
Poor wound healing.
Sorry?
Wounds that don't heal very quickly.
Okay. Thirst. Exactly.
Dizziness.
Dizziness. Exactly. All right, so that's high. What about low? It's a short test. It's a short test. Feeling weak? Mm-hmm.
Shaky.
Mm-hmm. Irritable. How about irritable? So if somebody says you're irritable, you can say, well, my blood sugar's a little low. That can be your excuse. If they say you're
You're a
irritable.
genius. You just found my problem.
All right, that's good. We solved the problem today. Very important. I was really surprised by the answer that I got for when I asked some people this question. How often should a person with diabetes check his or her feet?
Every day.
Every day. I had one person to say every 6 months. They said, a person with diabetes to say every 6 months. And I was blatant with them. I said, if you check your feet every 6 months, you might not have it. So,
Can I ask you, what is checking your feet? I mean, exactly.
oh, that's literally taking off your shoes, checking for wounds, ulcers, and any kind of problems, any kind of damage to your feet, making sure your toenails are cut properly. So that's actually physically, you're gonna get it now, checking your feet. I'm sorry? Swelling, exactly.
Athlete's foot that doesn't heal, rashes that don't heal.
Exactly. Any kind of issue for a person with diabetes, dealing with their feet should definitely be checked out by a doctor if they identify something that's a problem. Another thing, since I've been doing this line of research, you always heard the term diabetic used to describe an individual with diabetes. That's not politically correct nowadays. You should not describe a person with their illness or condition. So to call a person a diabetic nowadays is not politically correct. So I always say individual with diabetes, person with diabetes, etc. So there's one note you can take away today, if not anything else. All right, so I'm gonna skim over this. So we did some analyses on the data. And here's some descriptives. So on average, our people were approximately 73 years old on average. We had about 45% male. We had a highly educated sample. On average, they had some college, but there was a wide range to a person with only 2 years of education to, we had some PhD and MD individuals in the study. Around 48% African American. Let's look at some of the conditions. We had about 46% that reported some neuropathy, which is close to what the literature says. Around 6% had a stroke, 73% had arthritis. So we did some multiple regression analyses to see what things were associated with life space, and specifically life space is our measure of mobilities. And one of the assumptions of multiple regression is that your dependent variable is normally distributed. So here's our distribution for life space. So it shows that we're not violating that assumption, and it's okay for us to go ahead and do that analysis. All right. So here we looked at demographics and measures of physical health as predictors of life space mobility. And this chart tells us that individuals who are older have a smaller life space. Males have a larger life space than females. Individuals with higher levels of education have a larger life space. African Americans have a smaller life space than Caucasians. And individuals who rate their health as being better have a larger life space. And finally, individuals who have, with diabetes, who've also had a stroke, they have a smaller life space. So that's when we use demographics and physical health as predictors. So we talked about health disparities, so racial differences in mobility. So we wanted to try to identify variables that would explain why African Americans, which could be substituted here for X1, well, we could substitute race here, so African American versus Caucasian. Here's our dependent variable life space. We have a racial difference here. African Americans have a smaller life space. We wanted to try to identify measures that might explain why African Americans had a smaller life space than Caucasians. So we wanted to find variables that either mediated or explained why we had that racial difference. Here are some possible things. So for mediation to be present, African Americans and Caucasians have to differ on that variable, and that variable has to be related to your outcome. So depressive symptoms, that could be a possible mediator. African Americans had more depressive symptoms. African Americans had lower cognitive function. They had less knowledge about diabetes, and they had higher levels of diabetes distress. They rated living with that condition as being more stressful than Caucasians. And these are things that are related to our outcome of mobility. So we added those to the models in separate blocks. When we added our mental health measures in, individuals with a higher cognitive status had a larger life space. Individuals who reported more depressive symptoms had a smaller life space. So adding these things to our predictive model, we still have a racial difference on life space mobility. So adding these measures of mental health did not explain why African Americans have a smaller life space than Caucasians. So we also added in our diabetes specific measures. So knowledge about living with diabetes and diabetes distress. So adding those in, we still cannot explain why African Americans have a smaller life space than Caucasians. So using all of these predictive measures, so if you could statistically make African Americans and Caucasians the same on all these measures, demographics, health, mental functioning, and these diabetes specific measures, you still can't explain why African Americans have a smaller life space than Caucasians. You can explain about a third of that difference with these measures, but it's still a significant difference. So some of the strengths and limitations of what we've done so far: the use of diabetes specific measures that are specifically related to that person and how they deal with their disease and what they know about their condition, instead of just general measures of those things. We have an oversampling of African Americans to make that racial comparison. And we use the sample of individuals that's made up of people from the community and people who come into the clinic. And with all research, when you're using self-report measures, you have limitations as far as what people remember, as far as are they giving you answers that they think that you want to hear for some of the questions. So that's some of the limitations of using self-report measures. So some conclusions from these preliminary analyses. We've identified some variables that are correlated with mobility limitation in older adults. So some possible areas that can be intervened upon include physical health. You can change your physical health through exercise and diet. Cognitive status, there are different training techniques that individuals can do to improve how fast they process information, etc. You can always increase your knowledge about a condition. And there are also coping mechanisms that you can do to deal with the stress associated with a stressor. So those are some areas that could possibly be intervened upon. And we found some measures that partially explain why African Americans have a smaller life space than Caucasians, but some more work needs to be done to identify some more things that can explain that racial difference. Finally, I'd like to acknowledge our funding sources. So psychology department here, Dr. Crow and I used part of our startup package to do some of this work. We got a pilot award from the Roybal Center, and I got an award from the UAB, MHRC, and CCTS. And all of our colleagues and collaborators, Dr. Crow, my co-PI, Dr. Ovale, our co-investigator, for his help with conceptualizing what we would do and recruitment through the clinic. Some of the staff, Peggy Mackey Bell, Martha Graham, Charlene Lee, graduate students, Larita Jones is here, Andrea, Leslie, and Tim, and our many undergraduates that have helped us make these numerous phone calls. And we have one of those assistants here as well. So I think this overview of what we've been doing so far and talk about disparities can open up any kind of discussion that we would like to have on the topic, and any type of ideas or concerns that anyone has about what we talked about. Yes.
Yeah. Glucose seems to be one of the demons in this process.
Mm-hmm.
When it's determined, and I'd like to know how it's determined,
Mm-hmm.
when it's determined that there's too much glucose in a person's bloodstream,
Mm-hmm.
are there any things that are done to try to reverse this process?
Oh, as far as when you take your hemoglobin A1c and determine you have too much, of course there are two different mechanisms that you can approach it. You know, one is medication, of course, and the one that I like to really focus on is lifestyle and behavioral changes. So changing your diet, you know, increasing your exercise, those kind of things to make your body more efficient and actually being able to uptake that into your cells and not leaving it out in your bloodstream. So I think those are the two pathways. Again, I like to kind of stay away from the medication as far as what I like to focus on, because kind of at that conference that I went to in DC, it was a conference of physicians, and they were talking about somewhere between 60 and 70% of individuals with diabetes can really reverse those effects through lifestyle modifications.
Okay, thank you. I have another question, but
Sure.
somebody else may have it.
Okay.
Very, very interesting. And I work with a diabetes study on campus as well.
Okay.
And so, however, the difference between our population is because you are from the from the Birmingham area, and we work in a rural population. So we use the same measure. I think ours is an 8-item or 10-item measure when we're trying to find out living space,
Okay.
as you mentioned. Did you say yours was from 4 weeks or 3 days? Because ours is 3 days, 4 weeks.
I was 4 weeks.
Okay, which I thought was pretty interesting, because with all of our diabetic clients, if you're diabetic, you have to go to the doctor quite often.
Right.
And so sometimes you go, and I think that's probably where the gentleman says you check your feet every twice a year because he goes to the doctor
And the doctor
twice a year.
checks it, yeah.
So going to the doctor, knowing these diabetic clients, sometimes they do go to the doctor up to once a month. Sometimes they go every other month.
Right.
It's very difficult for me to see somebody not being able to go outside of that living space, that restricted living space, because you go to the doctor. Now, with my rural population, a lot of times their doctor may be, of course, in rural communities,
Exactly.
their doctor is a lot farther.
Right.
So it makes me also think, how did you look into them having insurance? Because without the insurance, you don't go to the doctor.
Right.
And without going to the doctor and not going to the doctor within 4 weeks,
Right.
being a diabetic client, diabetic patient, being a person with diabetes, I appreciate that. Being a person with diabetes seems very alarming. So did you look at the fact of your participants having insurance?
Right.
Does that make sense?
It does, it does. One thing with our sample is 65 and older, so everyone at least has Medicare.
Okay.
So we asked them, do you have a source of primary care? Somewhere between 95 and 97% of the individuals said that they do have a source of primary care because since they do at least have Medicare and Medicaid, that they can get those visits paid for and they can get services. Now, of course there are differences between Medicare and Medicaid and private insurance, but based upon what doctors accept which. Sometimes, I don't like to say this out loud, but sometimes doctors will prescribe different things depending on if you have Medicare, Medicaid, and if you have private insurance based upon the reimbursement rate.
And did you see if they saw their physician regularly? Because if they don't have a car,
Right,
doesn't matter if you have Medicare.
right, that's right.
So did you ask to see if they were seeing their physician regularly?
We did,
Okay.
and we controlled for a number of physician visits. In those analyses, number of physician visits
Okay.
was controlled for. And one thing about the life space measure, the total score is affected by if you were able to get into the car and drive there yourself, or if you had to get someone actually to drive you there. So if you need assistance, if someone actually has to come and get you and take you to the doctor, then your life space will be lower because you needed assistance to do that. Yeah. Question in the back.
One is a comment, one is a question. The
Yeah.
comment is that the example you gave of the dog
Uh-huh.
who could sniff, there's been a lot of research done recently about possibly using dogs to sniff out cancer in patients as well. I mean, it seems to be kind of an up and coming
I agree.
area, which, there are obviously all kinds of practical issues with that, but my question had to do with, and I apologize if I missed this, but
Okay.
did you also look at the delay in diagnosis? Was there a difference in terms of how long people in these various groups had
Right.
conditions or
Right.
signs of diabetes before they actually
Right.
presented to a doctor?
That's one thing we did ask them about. It was not controlled for in this analysis, but we did ask them at what age did they receive their diagnosis. But of course, that was self-report. That wasn't anything that we could pull from their medical records. So, some individuals didn't know. Then the individuals who gave us an idea, some gave us a range. So it was kind of tough to get that from their self-report. The best way would have been able to actually, if we could have been able to pull their medical records and get it.
Right, because I'm just thinking that could drastically
Oh,
affect
definitely.
their mobility
Yeah.
and how far progressed
Mhm.
disease was.
I agree. Back in front.
The blood sugar levels are also very important
Yes.
in assessing diabetic conditions. How can an individual check blood sugar levels
Mhm. Yeah.
readily?
Yeah. Now, one thing that they've done, they've developed a lot of kits that you can use in home to check your blood sugar levels. So it's really not a complicated process as it had been years ago. They've simplified a lot of the kits and I suggest that everyone should have a kit to be able to test their own blood sugar levels in home.
Yeah.
And I think they've also reduced the amount of blood that's required in the kit to check your blood sugar levels. So, and especially, since these individuals at least have Medicare and Medicaid, they should have free access to those.
Behavior can be an indication, a partial indicator of whether blood sugar levels are appropriate. But then there are instances where glucose levels go beyond, and the individual, like the man in the photograph, perhaps didn't know it at all.
That's right.
So
That's exactly right.
that's where perhaps checking that blood sugar level is crucial. It's
Exactly.
really important,
Exactly.
especially if you're over 65.
I agree.
Yeah.
I noticed in a couple of the slides there's pretty significant gender disparities. And I was wondering about the gender disparities, like what accounts for them.
Yeah, that's something that's a little weird because, as you know, females have longer life expectancy than men. But if you're doing studies specifically with older adults, it seems like no matter what physical health measure you put in the study, men always do better than females. So I don't know if it's something about recruitment biases between men and women as far as who participates in the studies, but that's common in studies of older adults for men to do better on measures of physical functioning than females, even though females have a longer life expectancy.
Well, I was wondering, because one of the slides was about people reporting about their disability levels.
Exactly.
And the things you said were walking a quarter mile, climbing some stairs, and housework.
Right.
And I was wondering if the women were saying that they were having a lot more trouble doing the housework because they
actually do
were
it.
expected to do the housework.
Right, because they actually do it. That's right.
And we're like, yeah, we're not having any trouble at all because.
Right. That's a good idea. That data came from the NHANES study, and that measure of disability, it looks at difficulty on one of a list of items, but that might be one item that if they took it out of and looked at disability based upon the remaining items, that might go away. Yeah.
Yeah, you would, just in your presentation today, but also in your other work, here are you, you're a psychologist. Some of this is very, very close to what a physician,
definitely.
one thinks might be.
Definitely.
What would you say is the difference between your approach to issues like this and a physician trying to figure out about health disparities?
I think with me, I'm more focused on, identifying things that could be changed and incorporating those behavioral changes to try to get an individual to, modify their own behaviors and, in a sense, fix their own problems to where, I see physicians more treating the symptoms, which, it's not the case in all instances. You do see some physicians that older adults, or some geriatricians that older adults go to who really like to talk to them more about behavioral changes and things like that. But, I see the physician's role more as, treating the symptoms, to whereas what I'm trying to do is identify areas where that person can fix their own problem. Dave?
Yeah, it's a great work, Olivio. I have a question about the issue of life space. And what was occurring to me as you were talking is, obviously you can't do a randomized design here.
Right.
You're either African American or you're white,
Right.
and you're not going to change that in
Right.
your methodology. And I wonder if by nature, the other aspect you can't change is whether we like it or not, most communities in Alabama are still segregated. African Americans live in African American neighborhoods and whites in white neighborhoods, so we can't change that either. So I wonder if in a normal sample, a healthy sample, whether those life space differences, I wonder if the nature of the African American communities versus the nature of white communities, whether they may be just life space issues based on the community.
Based on the communities. Yeah, I think about the closest research that I know upon that is some research that Richard Alderman and his group did, the UAB study of aging, where they had 1,000 older adults and they selected half from urban communities, half from rural communities, and they controlled for whether that person lived in an urban versus a rural setting, and they still found these same type of differences. Now, I guess something that could be done if your sample is large enough, you can really cluster individuals by the neighborhood where they live and see if you have differences there. But you know, you'll need a large enough sample and a large enough number of communities and individuals from those communities to do that analysis. So that is possible to try to tease that apart. Yeah.
Just to follow up on David's question, I'm wondering if the answer isn't in the socioeconomic status, that there you might find uniform correlation across origins. And it'd be interesting to look at this data that you're collecting already. You might even already have the data and display it in terms of socioeconomic context and see if those correlations hold.
Yeah, I definitely think, you know, to help with that, we would need a sample that was really more representative of the population, because as you can see, our sample was highly educated.
Yeah.
So to be able to find a sample that was more representative of the individuals who live here would definitely help in that. Yes.
And I think this might be under the skill D that you were talking about, but I wonder how much of it too has to do with health beliefs, that, oh, my feet hurt, I better not move, I better sit still. You know, I mean, those kinds of things can be very culturally embedded.
That's true.
And yeah, I would be interested to see if that has any bearing on it as well.
Yeah, and one thing that we're going to add, that we've added into the 2-year interview, we've added measures of physician trust and perceived discrimination. Because sometimes in African Americans, you know, even though they have access to a physician, they have a regular physician, you know, their amount of trust in what that person is saying, or if they've experienced any kind of, you know, perceived discrimination in a healthcare setting, might make them more likely to delay, you know, actually going to see their doctor. So that's something we've added in our 2-year telephone interviews that we'll be able to look at as well. Let me go here and then I'll go to you.
Did you ask them if they had a car?
We asked them if they have transportation difficulty. We do have that question. We don't ask them specifically,
But
do
you
you
see,
have a car?
I mean, if you don't have a car, you could have great mobility, but somebody would have to come and get you and they would be driving. Do you know what I mean? That would
I do.
separate out whether there's an economic issue about not having a car or a license. Might be a question you might wanna.
Okay. Good point.
Have you come across any studies that, like, overall look at life states of even younger individuals? You know, there's this greater than just the fact of, yes, you're looking at an elderly diabetic population, but if generically, well, I don't want to use the word generically, but for lack of a better word, African Americans really just don't move a whole lot.
Right.
You know, you wouldn't expect to see any change just because they're diabetic and 65.
I have it myself because, you know, this is a measure that was specifically designed to use in an older population, so I haven't really seen it translated into, you know, younger adults. Yeah. In the back, and I'll come to you. Yeah, Dan.
I was just on the self-inspection. You mentioned about the self-inspection and how often you check your feet. But you also mentioned that a common aspect of the diabetes is visual impairment.
Exactly. Retinopathy.
So that's a real complication for people who are living on their own, I presume.
Oh yeah, definitely. And you know, as you know, not only is your visual functioning is related to a lot of things. It even ties into your cognition in some ways. So if you have visual problems, you've got mail coming to the house, you have to deal with that. You know, you have medication that the doctor gives you that you have to read the instructions on how to take it. So your vision is very important when it comes to a lot of other aspects, and individuals with diabetic retinopathy definitely have some issues. Another question on the skill D asks, how frequently should you have an eye exam if you have diabetes? And an individual with diabetes should have an eye exam at least once a year. So, you know, your average individual probably every 2 years, but for an individual with diabetes, they should have an eye exam every year. Yeah.
Boy. I got to listening to you and I forgot.
Oh, no problem. Maybe I was saying something good.
Yeah, well, here it is.
All right.
the onset of diabetes, I happen to just have some information, personal information about that from
Okay.
members of my family.
Okay.
But the onset of diabetes and cardiac problems and cancer
Mhm.
can be recognized at, say, age 40.
Exactly.
And
That's exactly
supposing you took samples between age 40 and age 65,
Mhm.
you would also notice differences in whether those people drive cars, or whether they have transportation, or whether they live far from a doctor.
Mhm.
So it might be just as interesting and relevant to touch the people between age 40 and 65,
Yeah.
or maybe a little earlier, but I think 40 is a good age, because many people discover suddenly they've got a cardiac problem, or they have cancer, or they have diabetes.
Yeah.
And I have a brother who lived with diabetes from the time he was 40 until he's 69 now.
Okay.
But he has improved fantastically,
Okay.
and he was not able to walk.
Wow.
He was not able to walk, but he can walk now.
Okay.
And so maybe you and I should get together
I agree. I agree.
about that. Yeah. Yeah.
But yeah,
Okay.
I definitely second that about the age difference, because there was a study on campus, the REGARD study, which is a national study of stroke incidents. And originally, you know, they were only including individuals that were, I think, 65 and older. But kind of like you said, they noticed that the age of onset of strokes for individuals, specifically African Americans, were getting younger and younger.
Right,
So
yeah.
their actual recruitment criteria now is 45.
Uh-huh.
So I think they have 30,000 individuals age 45 and older, and they're studying stroke incidents.
Great.
Yeah.
Great. Thank you.
Well, are there any more questions? Well, thanks very much, Dr.
All right, thank you guys for your attention. I appreciate it.